We can start, bro.
Hey Hari bro, over to you.
Thank you. Good evening, everyone. Myself, Sri Hari from Kapam Faculty of Medical Science and Research, currently the West Zone Coordinator of IMA-MSN Tamil Nadu Students Network. And it's a privilege for me to serve as a moderator for today's session on behalf of Indian Medical Association, Medical Students Network, Tamil Nadu State Branch. On behalf of IMA, Medical Students Network, and Junior Doctors Network, Tamil Nadu State Branch 2026-2027, I extend a very warm welcome to all the respected dignitaries, our esteemed speaker, and all the participants who have joined us today for this informative seminar on SciTB, the next generation of TB diagnosis. At the beginning, I would like to respectfully acknowledge the constant guidance and the encouragement provided by the patrons of IME Tamil Nadu State Branch. Dr. V. Sridhar Sir, State President, Dr. P. Senguttuvan Sir, IME Past President, Dr. A.K. Ravikumar Sir, President-elect 2026, Dr. N.R. Tyagarajan Sir, President-elect 2027, Dr. M. Thiravyam Mohan Sir, State General Secretary, Dr. D. Solomon Jaya Sir, State Finance Secretary. I would also like to convey my sincere regards to our state leadership team, Dr. R. Annamalai Sir, Chairman, Dr. S. Jamunarani Ma'am, Co-Chairman, Dr. V. S. Hariharan Sir, Chairman, Dr. Kannan Rajendran Sir, Convener, IMA-MSN Subcommittee, and a special appreciation to the state team members who continuously support the activities of the Medical Students Network, Arnagiri Sir, Convener, Ajay Karthik Sir, General Secretary, Bala Hariharan Sir, Co-Convener, and Hariram Sir, Co-Convener. So, over to the seminar topic today. Like for over 100 years, the tuberculin test or the Mantoux test was the global standard. However, it has a major flaw. That is, it cannot distinguish between the real TB infection and the BCG vaccine. So, SciTB is the missing link in our global strategy. So, it gives us the diagnostic power of a molecular laboratory in the palm of the health worker's hand. So, finally, allowing us to screen and treat latent TB at a scale in communities that need it most. So, as of World TB Day, that is on March 24, 2026, the WHO has officially shifted the global strategy towards the near point of care molecular tools. So through the seminar, we will get to know that we are no longer limited by the walls of laboratory. By combining the immunological precision of SciTB with the portability of NPOC and NAT and the intelligence of artificial AI, that is artificial intelligence, we are finally equipped to find every case and close the gap in the diagnosis and truly end TB by 2030. So now, it's indeed a pleasure to have with us Ms. Mukia Tavasini, Government Medical College, Tiruvallur. As a student researcher, her work involves looking beyond our standard textbooks to see how emerging technologies like SciTB are practically changing the way we will practice medicine in future. So to add on her tribute, like she has co-authored a research paper titled Detection of Latent Tuberculosis in Chronic Kidney Diseases, that is CKD patients on dialysis using the SciTB test, an hospital-based cross-sectional study published on Curious Journal, which is a part of the Springer Nature publication. So without further delay, let us begin the today's session. I would like to invite the session speaker to kindly deliver her talk and share her valuable insights with us. Over to you, ma'am. Thank you.
Thank you, Stephen, and thank you for this wonderful opportunity. And let's see. So, very good evening to one another present here. I am Mugia Tavasini, final year MSc student, Government Medical College, and I'm here to elaborate an exciting topic, the next generation of interaction, that is SciTB. And these are my objectives: introduction to and latent action, diagnostic test available for TB and introduction of site TB, advantages, how to administrate and interpret the site TB test, adverse reaction, interesting reaction, indications and contraindications, and finally limitations of site TB test. First, the introduction. Tuberculosis is a treatable and preventable infectious disease caused by Mycobacterium tuberculosis bacteria, which primarily affecting lungs, that is pulmonary TB. It is spread through the air when people with lung TB cough, sneeze, or spit. It remains one of the most significant global health threats. We know India are the capital of TB, who reports 10.7 million TB cases and 1.23 million TB-related deaths in the year of 2020. Common symptoms of tuberculosis are prolonged cough, sometimes with a pet, chest pain, weakness, fatigue, weight loss, fever, and night sweats. Current diagnostic tests available for are TB skin test, contacts, TPD, purified protein derivative, blood test, that is IMA, chest X-ray, sputum test, molecular test like gene expert, CBNAT, smear microscopy, or culture. So, before enter into the topic proper, that is IT, we should know about latent TB infection. LTBI is the persistent immune response to Mycobacterium tuberculosis antigens without clinical, radiological, or microbiological evidence of active disease. TB bacilli are present in small numbers contained in granulomas and metabolically active or slow replicating. The persons affected with latent LTB doesn't have any symptoms, no cough, fever, weight loss, or night sweats. The only investigation we can do is immune-based test like TST, that is tuberculin skin test, IGRA, or antigen-based skin test like cycling. We will go through one by one. First one is Montauk's test. Kindly note how they are noted the swelling. So, exactly practiced in the scientific test. A small amount of tuberculin is injected under the skin on the arm. The healthcare workers check for swelling 48 to 72 hours later. We have to note the swelling and for the induration we have to interpret for Montauk's test. For the intra, it is a blood withdrawal test. First step, blood collection, collecting a blood sample from the individual. Second step, T-cell stimulation, stimulate T-cell with TB-specific antigen to trigger the release of interferon gamma in antigen-coated tubes. And the final step is, we have to measure the interferon gamma using ELISA. IGRA examples are quantiferon TB code. These measure how the immune system reacts to the TB bacteria. And we are entering to the topic proper, sighting. It is an intradermal skin test like Montauk's developed by Serum Institute of India to detect TB infection and latent tuberculosis infection. It is a TB-specific antigen-based test using recombinant early satisfied antigen target 6 and culture filtered protein 10 antigens. These are the main antigens used in the site TB, which are present in only Mycobacterium tuberculosis, but not in BCG strain and most environmental Mycobacterium. So this is the site TB vial. We have to administrate 0.1 ml in the forearm. So the next generation test for latent TB detection to diagnosis, detect and defeat TB as well as LTB. Here note, 25% of the esteemed world population is infected with latent 5 to 10% of latent TB individual gets active TB disease in their lifetime, and 40% of Indians live with latent TB. Any questions from Can I proceed, guys?
Right, you can proceed. You can proceed. We have a question in the last.
Okay. So now we can clearly see how site TV is dominating the TST. TST will produce a false positive. How it will cause a false positive is TST tuberculous skin test will cross react with BC strain and non-tuberculous mycobacterium. Here, site TV selectively detects the main two antigens that was recombinant dimer, early stratified antigen target 6, and recombinant culture filtered protein 10, which are MTB specific, eliminates false positive in the previously BCG vaccinated population. This is the key advantage over the first generation DST test, especially in the developing countries like India with the BCG vaccination programs. And these are the other advantages. First advantage we know it will not cross-react with BCG vaccine. Second advantage, no sample handling. For example, IGRA we need well-trained lab technicians and lab infrastructures. Here for site TB we don't need anything. One trained lab technician is enough to administrate site TB test. Easy to administrate. Like Montax, we can easily administrate intradermally. Special population are covered. People living with HIV and pediatrics populations are also covered for site TB test, which was not covered in PST. Point of care test performed in the field without any lab facility and convenient 10 doses per vial. For one vial, we can 10 patients. This is excellently suitable for programmatic implementation. Now we can compare the site TB with TST and IGRA. First thing, specificity. Site TB has highest specificity more than TST and IGRA. For TST, it will cross-react with BCG vaccine, and for sensitivity, every test have equal sensitivity. Ease of use. Here, IGRA is dominated by site TB. Field friendly and IGRA needs lab and infrastructure, and single cutoff allows simple test interpretation. TST have complex test interpretation. How complex is? We have three interpretation. More than 5 millimeter is positive only for high risk patients like people living with HIV and immunocompromised patients. More than 10 millimeter induration is positive for IV drug addicts and children. More than 15 millimeter is positive for non-risk. This is for TST. And IGRA we need lab technicians and lab infrastructure. Cost of test is low in TST and site, which was high in IGRA. And manufacturing. Robust with high yield, large quantity and standardized quantities are obtained in the site TB. Here, TST, complex old products and many antigens are used in TST. IGRA, we need ELISA, multiple components required, and it is complex. As I already mentioned, children and people living with HIV, for site TB, it has more reliability. Now we are going to see how to administrate and interpret the site TB test as per the standard operating procedure, which was developed by National TB Elimination Program. What are the materials we need to have to administrate site TB? Site TB vial, 1 ml containing vial there, we can put 10 test. And the syringe, 0.1 ml syringe is available. We can use insulin syringe also. Cotton balls, alcohol swabs, and gloves, puncture resistant short disposable container. Recording from Nikshay, we have to register in Nikshay, whether it is digitally or physically. What and all the things we have to enter in the Nikshay is name of the patient, father name, and address, phone number when we are administrating and where we are administrating the scientific test. Now we have to administrate. This procedure is very much identical intradermal injection for contact test on forearm. First, wash the hands and wear the gloves. Under the clean environment on well-lighted surface, we have to select the injection site. Injection site most preferable is left to forearm, 2 4 inches below the elbow, and slightly flex at the elbow. Avoid areas like veins, sores, rashes, scars, or excess air. All this will interfere with this breathing. Clean the injection site. First, we have selected the injection site. Now, we have to clean the injection site with an alcohol swab using circular motion. We know from the center to periphery we have to clean and allow it to dry completely before injection. Mix the oil, inverting mix gently. Load 1.1 ml of solution in the syringe with the needle up to person's. Insert the needle slowly at 5 to 15-degree angle just below the surface of. Slowly inject the solution. Most important thing is we have to form 6 to 10 millimeter wheel. This was a very important step, and after the wheel formation only we have to confirm that we have put the injection correctly. And something we have to tell the patients, avoid scratching and keep the site clean and dry, and avoid heat, lotion and adhesive bandages. We should not put any adhesive bandages as it would cause irritation. It all will interfere with the result. Inform the person that it is important to return within 48 to 70 days. Have the result. If the patient unable to come to 48 to 70 hours, don't give injection. It is a waste of source. He cannot read before 48 hours or after 70 hours. The result will be faded. And reading of skin reaction. Exactly mentioned in this picture, we have the plastic that is reading should be performed under elimination with the forearm slightly flexed at the end. Not measure the red arcs. If the redness is more than 10 millimeter, we should not measure redness arcs. Presence of induration only we have. First, we have to inspect how much induration is present, and we have to palpate slowly and mark the full extent of the induration, and we have to measure the diameter of the induration. So what is induration? It is palpable, raised and hardened area or swelling. Other than that, and the redness, we cannot measure. We have to measure, we have to mark it with the ballpoint pen and plastic ruler, we can measure it. Interpretation of skin reaction. Universal cutoff is 5 millimeter. If the induration is more than 5 millimeter, then we can definitely say the test is positive. Formation of vesicles, ulnar, lymphangitis, ulceration, and necrosis at the site of injection indicates that high degree of sensitivity and hence the presence of the infection. We have to note only redness and only we have to eliminate. Other than that, vesicles, bulla, we have to note, and it indicates high degree of sensitivity. A negative test indicates less than 5 millimeter. Lack of infection with mycobacterial tuberculosis, or that the person has required infection very recently or not enough time has elapsed for body to react to it. If the patient doesn't develop the induration, we cannot blindly say they don't have the teeth. He may require some time pain, induration. What are the adverse reactions we can commonly notice? Injection site pruritus, pain, hematoma, rash, vesicle, erythema, and swelling, mild headache. It all self-limiting. Most of the patients within 48 hours they will settle. Uncommon adverse reactions are injection site induration, pyrexia, hemorrhage, ulcer, and discoloration, malaise, influenza-like illness, and fatigue, dizziness, arthritis, rash, gastroenteritis, myalgia, and diarrhea. If these uncommon adverse reactions are persist, we need to seek a healthcare center. And rare adverse reactions, injection site inflammation and anesthesia, paresthesia, head discomfort, urticaria, night sweats, eosinophilia, lymphangitis, and hepatitis. These reactions are persist. We need to take these healthcare center. And now, what is boosting reaction? This is an interesting thing in the scientific. When sensitization to mycobacteria has occurred many years earlier, an initial TST may produce negative or weakly positive responses. There being two sensitized lymphocytes in circulation produce a significant local response. If the test, however, is repeated, a larger reading may be obtained due to immune response being recalled or boosted by the first test. After we are administering second test, it is called testing. Testing is a maximum within 1 to 5 weeks of the initial test and may continue for up to years. The second boosted reading is considered for decision making or future comparison. Nothing. If you are doing initial TST, within 5 to 6 weeks, we should not administrate scientific or again TST. If you are doing it, duration may be obtained due to immune response. We know it is a false response. We cannot take it as a good read. So, thus, in standard practice, what they will do is repeat scientific test can be performed population with negative result at interval of at least 6 weeks. Now, indications and contraindications of scientific. Indication of test for for reduction of TB infection for the population age 18 and able. Contraindication if the patient has hypersensitivity or severe reactions to previous scientific test.
Yeah.
Now, the limitations. There are 4 limitations even to the scientific. First, cannot distinguish latent or active TB. If we administrated scientific, we have read it and we saw it is positive. We cannot say latent TB or active. Without active, we should clinically evaluate and we should take chest X-ray and microbiological test without active. Next, 2% requirement. Here, so many patients, we can administrate the scientific, but we will not follow the duration, 48 to 70%. This is the one limitation. And next is overall protein repetition. As I mentioned in the boosting reaction, within 6 weeks, we cannot administrate the scientific. After 6 weeks only, we have administrate scientific. If you are doing it, there will be a boost reaction, large reading will be present. And operational, last thing is operational challenges. One well-trained lab technicians is required to feed and to maintain cold chain and to properly administrate and reporting into the next chain. So these are my references. Thank you. Any other questions?
Is there any questions from the audience? You can just drop it in the chat box.
Any questions? Please raise your hand or please drop in chat box.
Okay, then I will consider that there is no questions from the audience.
Okay,
Thank you,
then.
Mugia. It was a very nice webinar from you. Thank you for
Thank you.
accepting and spending your time here. It has more clarity in that. Thank you. We'll move to the word of thanks from Srihari. Sir.
So
Srihari, sir, over to you.
a huge thank to our am I audible? A huge thank you to our speaker and attendees for making the SciTV seminar a great success. Let, let us keep spreading the awareness and keep working towards the TV future. And special thanks to the Indian Medical Association Medical Students Network and join Junior Doctors Network, Tamil Nadu State Branch, and organizing team Darshini GS, Joint Secretary, and Parthasarathi S, Joint Secretary, Akash J, North Zone Coordinator, and from Tech Team, we have Trishik GS, and all the participants for having attended the session. Thank you. Thanks a lot.
Thank
Thank
you.
you.
Thank you so much. Thank you.
Thank you, Mugia. Thank you all. The
Thank
meeting
you.
is over.
Thank
You
you.
can leave.
It's a really good study, Mugia.